Hello and welcome to this video. My name is Kris, I'm an Australian GP and it's the beginning of the year, which means that there is a whole host of new interns starting in the Australian healthcare system in 2023. If you're one of them, congratulations, welcome, and I hope that your first few weeks of work are not as terrifying as they feel like they're gonna be. I am now 7 years post graduation, so it's been 6 and a bit years since I was an intern, and I still remember it vividly. So whilst I am now a GP, fully fellowed, all done, my internship feels like it was just yesterday. And one of the topics I'm really passionate about, mainly because I am now in the general practice space, is that of discharge summaries, which you're probably sick to death of hearing about already. They can be confusing, they can be a bit mystifying, they can be really daunting, and I remember getting so annoyed by medical administration who don't work on the floor being like, you need to get your discharge summaries out. It's like, I know, Sharon, I'm working, I'm busy, there are so many things, I'm trying to learn a new system, I'm trying to learn the bosses, I'm trying to figure out how to cannulate again. I get it, it is intimidating. So what I want to do, and I've done one of these videos before, which I'll link, this will probably echo a lot of those sentiments, but it has been a few years, which is crazy to think I've been doing this for a few years, but anyway. I wanted to break down sort of 10 tips that I as a GP wish that I knew as an intern, but also hope that my interns, or that the interns in the community know about discharge summaries from a GP's perspective. I'm hoping to be informative and not judgy because, trust me, I remember I was there once. So, number 1, discharge summaries are clinical handover documents. So, think about it like you are handing over from emergency to general medicine, or from general medicine to ICU, or to ICU to gen surge, or from pediatrics to mental health, like any interdisciplinary handover where you would write a letter, for example, or like a note to try and communicate clearly. That's what a discharge summary is. So it needs to have up-to-date information, be professional, be polite, get to the point, and include anything really relevant. The second thing is the best discharge summaries are the ones that arrive, preferably on time. I've had so many, I can't even count. It's in the thousands by now. So many patients who come in and they're like, so I was in hospital. And you go, okay, I had no idea, because we don't get notified when our patients are admitted, we don't get notified when they're discharged. The only way we know a patient's been in hospital is we get a discharge summary, or the patient calls us and lets us know, or something like that. But like, we are so separate. Quick disclaimer, I'm in Queensland, so I'm going to be talking about probably Queensland-centric things, because I appreciate I don't think it's Australia-wide, some of the things I'll talk about, but same. We don't get notified. So the best discharge summaries are the ones that arrive and are timely. A lot of the time, and I remember this as a junior, we encourage patients to follow up with their GP within a week, 2 weeks, the next month, whatever. If your GP doesn't know you were in hospital, we can't assist you with that. So a timely discharge summary, one that's delivered within a day or two of the patient being in hospital, is really important. Now, the best discharge summaries actually leave the hospital with the patient, but I appreciate that this is not always possible. So, because I remember. So the best discharge summaries are the ones that just get sent, preferably on time. So my third tip really echoes the first one, in that please remember that you are writing to a specialist colleague. Just because we're GPs doesn't mean we're any less specialist than a cardiologist, rheumatologist, pediatrician, etc. So your words, the mannerisms, the way that you ask us to do things matters a lot. There is a lot of disrespect for GPs out there, sadly, and I think I've talked ad nauseum on that too. So I don't intend to, rehash everything, but just know you are writing to a specialist colleague. So just be collegiate, just be polite. Don't tell us to do things like chase, because that kind of sounds like a dog. We're not the community intern either. We are specialists in our own right. So it's important just to keep that in mind when you're writing a discharge summary. Number 4, and I have already touched on this again, they're all very interconnected, is that your discharge summary is the only thing we know about the admission. We have no access, at least in Queensland, to any of your notes during the admission, to none of the images, just the reports of things. And even then, things have to be signed off before we can see them. So we can't see your interim reports. We can't see blood tests that are not yet finalised and things like that. And sometimes the viewer, which is the portal we can log into in Queensland to see things, is not up to date. So just be aware that what you tell us is all we know about the admission. So tell us the important stuff. Patient presented with this symptom. These investigations proved to us that it was this condition. We treated it with this. I don't need to know how many bags of saline was given, or, you know, what percentage of glucose was given, although sometimes that can be useful, but I don't need to know that sort of stuff. I need to know, was admitted for 3 days of IV antibiotics, this antibiotic at this dose, discharged on orals, but this is the plan. Like, that's the sort of stuff I need to know. I don't need to know, you know, had nursing care and had TED stockings and things like that. It's not relevant unless it is. If there is a continuation that you want me to do in the community, then it's relevant for us. But again, all I know about the admission is what you write. So if you say, came in with chest pain, discharged on Clexane, I have to fill in the gaps because I don't see the notes that say, and then we found out he had this and that and the other. I also don't get to see special things like ECGs. I don't get to see any of that. So literally it's radiology reports. So anything you can attach is basically all I can see. Blood test results and what you write in the discharge summary. No notes, no nothing. Nothing from allied health, nothing from specialists, nothing. Number 5. Including medications is super helpful because they don't always pre-fill. So more important than just medications is any medication changes. So there will be a section in Enterprise Discharge Summary to fill in, you know, medications. Is this changed, unchanged, temporary, permanent, and why? That's really important for us. That's really, really, really important because we will be continuing it in the community. At least you would presume so. So if temporarily you reduced a furosemide dose because the GFR was, you know, not doing so well, with the plan to repeat a blood test and then reintroduce the furosemide at the previous dose, please write that in. You know, temporary change, reduced dose due to GFR under 50, once GFR over 50, return to 40 milligrams or whatever. That's super, super, super helpful. And if you see something and change it, you know, ceased loratadine to start, I don't know, another one, okay, let us know and we will do that. Unless our better judgment says that we shouldn't, but that's another thing. So yes, including medications is super important. And I appreciate, especially in Queensland, or at least the hospital I worked in, it's the duty of the pharmacist sometimes to do this, especially for long stays in the general medicine ward. But if you're getting a timely discharge summary out and the pharmacist can't be a part of that, you as the intern, the junior, the doctor writing it, can and should. So it shouldn't just be, well, the pharmacist can't do it, so it won't go in. No, guys, it's really important for us, so please try. Number 6 in the same vein, kind of already touched on it, so very quickly, please include any relevant and important and most up-to-date imaging reports and blood tests. Like I said, we don't always see everything, and it's nice just to have it in a document, because one thing I haven't touched on is how long and hard it takes to get on to the viewer, because sometimes it's down, sometimes it takes 20 years to load. Just be nice if it was all in the discharge summary. Thank you. Number 7, medico-legally, if you order it, you're in charge of the result. So say you order a urine MCS on a patient and the culture isn't back yet and you think they're clinically well to be discharged, and you put in their GP to please follow up the results. Well, technically it's actually your job, and that's medico-legally. You can talk to your indemnity insurance provider about it, but if you order it, you are in charge of the result and the treatment of it. So if it comes back as an E. coli UTI, do not presume we know that, because unless you CC us into the result and have written to us, and that letter or discharge summary has arrived to us and we're aware that we are now taking on that responsibility, that patient's going to have an E. coli UTI until I don't know when. And then that could, you know, potentially turn to a pyelo and stuff like that. But anyway, if you order it, you are in charge. Unless you've had verbal confirmation of handover of care, do not assume, please, that the GP will take the responsibility from here. And if you want us to follow up on a result, please CC us in and let us know why. You know, patient well enough to discharge, pending this, You know, if it comes back, treat it. Like, it's hard. It's hard. I get it. It's really hard to be like, can you check over? But that's it. Takeover of care. Discharged, pending this, takeover of care. Yes. Like, just give us a call even. And just let us know, hey, we're discharging, but we're just waiting for this. Could you please check on it? At least then we can verbally say, yep, cool, I've taken over care. Because otherwise, it is your responsibility still. And that goes for anything you order. Blood tests, urine cultures, imaging, anything. In that same vein, what are we up to? Number 8. If you want us to follow it up, please CC us in. We don't always see everything. It is so easy to call the lab and say, hey, for anything pending for Mr. Smith, could you please forward it to the GP? Done. Easy. 30-second phone call. Even nicer if it was on the piece of paper to go with, but sometimes you don't know when a patient is going to be discharged, so fine, make the phone call. Number 9, if the plan is to have another physician, the community physician in this case, the GP, review a patient in a timely manner, say in 3 days for a dressing change or whatnot, help us out by please getting the patient to call and book that appointment while they're in the hospital, or can you call and make it for them? I know it sounds like such menial work. You're not their assistant, you're not my assistant. Thing is, especially if a discharge summary doesn't come on time, which I appreciate the pressures, I do, then if we get the please see your GP in 3 days as part of the plan and it's 7 days post, we really miss the boat. Also, patients don't always realise, but they have responsibilities for their own health too. So they should be booking that appointment, but sometimes they assume that you're booking it. So just that clear communication. Hi, Mr. Smith, I want you to see your GP in 3 days. Can you book that now or shall I call? If there is something urgent you want us to follow up on, say like a sodium or a potassium or something like that, call us. It is so easy to call us and just say, hey, I've got your patient, or a patient who sees you, Mr. Smith, Jones, I can't remember what fake name I gave now. He's come in with this. His sodium, we were happy to discharge, but we really want to repeat in a few days because if it does this, then this means X. Would you mind seeing him and getting that done and seeing the result? Done, dusted, we can book them in, that's easy. Or even chat to our reception team. Like, we do make allowances for patients who have just come out of hospital. We are chockers, full, but I can, for example, I always have 2 on-the-day slots that I can have pre-filled or filled in on the day, as the name suggests, so it's possible. And finally, number 10, please make sure that you've got the right GP listed in your system. This should be done when the patient is admitted, but depending on the scenario, sometimes it's not the priority of the admin staff, the physicians, or the patient to talk about the community physician in charge of their care. So before they go, can you please clarify with the patient who they plan to see, or at least the right clinic? The right doctor would be beautiful, but at least the right clinic. Because if you send a discharge summary to the wrong person, then it's null and void. It means nothing. We can't do anything. You send it to I've already used Smith and Jones, to Dr. A, and they're seeing Dr. Q. Dr. Q got no idea at all what's happened, especially if they're at different clinics. So please double check who it is before they go and just call the patient. You know, if they've already been discharged and you're doing it, just, hi, just wanting to clarify who you want your discharge summary to go to. Cool, thanks. Done. Easy peasy. So there you go, guys. 10 tips about discharge summaries, basically GP's rant. Sorry. Trust me, again, I do get it, and I hope to come from a place of just wanting to educate and be passionate about continuation of care and our patients. But if you have any questions, let me know. Hopefully your hospital in its orientation will be talking to you about discharge summaries. It's part of the job. It's a bit of a sucky part of the job, but it is part of the job. If you have any requests for videos that you want me to cover, let me know. But until next time, guys, stay safe, stay healthy, and I'll see you in a video very soon. Bye.